TopMedTalk.
Well, hello and welcome. It's day 2 of the annual meeting of the American Society of Anesthesiologists, Anesthesiology 2021. We are live in the exhibit hall in sunny San Diego. I'm Desiree Chappell, your host, and I'm joined by my colleague, Professor Solomon Aronson. How are you, Sol?
I'm great, Desiree. Stay classy, San Diego. It's so nice to be, in a real city, seeing real people.
I know. It's great. It's hard not to hug everybody.
I know.
Lots of fist bumps happening here in the exhibit hall for sure.
Yes.
But I think that there's a buzz and excitement kind of like I haven't felt before.
And it's, good for the Society of Anesthesiologists to just bowl through and make the statement to do this. And we really appreciate them hosting us for this meeting.
Yeah, we surely do. And I know everyone is very thankful to have for the ASA to have gone through with it because it was time for sure. And we do want to thank the ASA for supporting us to be here this year at the meeting here in the exhibit hall to have some really great, fabulous conversations with some of the speakers, some of the committee members, the constituency about all the great work that the ASA is doing. So thank you to them. Now today we've already done a couple conversations already.
Yesterday and today, so we're well into it.
We are well into it. All the information can be found on our site, Saul.
Live.ebpom.org. Thank you.
All of our conversations are already up online. You can watch the videos of those. We also have them on our podcast. So any podcatcher, you can find them on TopMedTalk or Editor's Top Pick. That's another source. So they're everywhere for sure. But without further ado, Saul, it is with great pleasure and actually a little bit of sadness because I was really hoping this could happen in person. But we're going to bring our next guest in via the Zoom call kind of thing that we've all been doing, but it's okay. It is a dear friend of ours, Dr. and Professor Lee Fleisher. Lee, it is so wonderful to at least see your face and hear your voice. I wish you were here.
I do too, but I wasn't allowed. So
that's right. I think, did you say this is the first meeting in 33 years that you haven't been able to be here in person?
I still remember going to New Orleans in 1989 as a fair scholar. Sitting next to our friend Michael Royson, and really enjoying it. But given that ASA invited me in my CMS role, the government is not allowing us to travel at this time.
Yeah, I got you. So for people who, I don't know who wouldn't, but for those who may not know you, Lee, you've been a professor of anesthesiology and critical care at University of Pennsylvania and among many other titles there. But you recently took on a new role, didn't you?
So it's now 16 months.
Oy vey.
And and I am the Chief Medical Officer of the Center for Medicare and Medicaid Services, and I direct the Center for Clinical Standards and Quality. So many of the U.S. listeners may have heard about the healthcare mandate that is being promulgated in the U.S. for COVID vaccinations. So I'm sort of home working with my team to get that out. We hope shortly.
Good. Well,
very exciting. But today I'm just, for full disclosure, I have to say I'm speaking as a professor of anesthesiology at Penn, and nothing I say reflects those of my agency at the current time.
That's
so noted.
So duly noted, and a dear friend of ours as well. We've had great conversations, Lee, throughout the years at our EBPOM meetings and as well as on TopMedTalk about a various array of topics. One of my favorites to talk with you about, well, it's definitely in the quality space, but also in the mental health, wellness, and safety kind of space. And there's been a lot of conversation around that, especially during the pandemic and us in anesthesia. And I just thought we'd take a little bit of time to kind of dive into that a little bit.
Absolutely. And I really, on behalf of what I would say the 147 million beneficiaries I'm responsible for, but just the patients I'm responsible when I give anesthesia, like on Friday, the anesthesia community has done so much to help care for those individuals, both as giving anesthesia, but in the critical care units, intubating on the floor. It's just tremendous, but it's incredibly stressful. I know what it feels like to wear those N95s for a lot of the day, just like I did on Friday.
Yeah. Lee, you actually, I kind of went back and I was thinking about some of these conversations. We started talking with you about, mental wellness, burnout, things like that, even before the pandemic happened. And so you were doing a lot of things within your department to really help, your colleagues deal with just the stressors of everyday job. Can you just walk us through some of the things that you had done there at UPenn?
Yeah, so we had done a lot of work around understanding sort of the psychological safety.
Yes.
And that to me is really the key point. And I was very excited this past year. I brought Amy Edmondson, who's written the books on that and is married to actually the dean of Harvard Medical School. So she has a deep understanding of this issue, but has done a lot of the studies around how do we both have accountability, which we all want, for our residents, for ourselves, but feel safe enough that if we do make an error, how can we learn? So that idea of high accountability but high safety, allowing somebody to learn, allowing someone to go home and process what happened during the day, was one of the themes that we had spent quite a bit of time and had an anthropologist ask our residents questions about this. In fact, our paper finally came out that said, the way that residents process it is they can't always process it from, no offense, you and I saw, sort of the old men, senior clinicians. Yeah. They talk to their friends and their spouses, and we need to find ways to give them that space so that those of us who have been there before, they can learn from.
Yeah.
And Lee, just so to parlay on that, one of our guests earlier yesterday spoke to this meeting as a burnout antidote, if you will, that the idea that we're actually going back into the world and mingling was really important. And I'm trying to sort of tether, if you will, that observation to the comment you just made, because I can't but help imagine that all the things you just said are multiplied by the fact that we're living in an isolation because we're all virtual and we don't have that same opportunity to go out and have a drink and have dinner and just sort of intermingle.
So it's interesting. We had done a study during the pandemic, and happy to discuss that more. We published it in the Catalyst last year, and we saw that anxiety causes burnout, not the opposite way around. We were fascinated by this. We thought burnout increased anxiety. But we live in this anxiety-provoking world with social isolation, and I think that an emotional contagion of negative emotions, and that increases that. I will tell you, giving anesthesia with 2 first-year residents, given what I do the rest of the week, was actually exhilarating, versus 14 hours on Zoom meetings. And I, a lot of our anesthesia colleagues are doing that all the time. But it was just so exciting to be with a couple residents, teach, interact with patients on a one-to-one. And I'm sure being there, interacting with other colleagues and learning is just the antidote to the world we're living in today.
Yeah, I think that there's a lot of, how do we deal with the stressors? It sounds like, one of the things is doing something different than we do every single day, just taking a moment to kind of step away. Because, when you are doing, in the world of anesthesia, doing day on, day in, day out, you're wearing the mask, you're doing this, it is a little bit stressful. Lee, what are some of the other ways that you feel like we can deal with this? Because didn't you work on some of this? I remember, didn't you put like a Peloton in the department?
You have a good memory. We did put a Peloton. I did my yoga to start my day. Yeah. We bought the Headspace app before it was given away before the pandemic. It's giving people space to do something different. I'm not going to make. It's very interesting as you listen to people talking, they're speaking more and more about the fact that it's not work-life balance, because some of us, myself included, actually like to go to work. and get enjoyment. So I think we need to say, what is it for each individual that gives them joy, and make sure they have it, so it doesn't feel like it's this constant, the external world, the pressures, etc. I mean, I greatly enjoy. I was so sad to miss Doris Keene Goodwin lecture yesterday. I heard it was phenomenal. But when I would drive down to Baltimore or D.C. from Philly, I would listen to her book. And God, that to me was an antidote to the stressors that I was under. So I agree, that's some of the goals.
So this is a what do you think question. Are we just more sensitized to burnout, anxiety because of the world that we're living in, because of the pandemic, and therefore talking about it more? But to your point, if work is joy, ideally, and we get joy from work, then why the heightened decibel level to the contents of burnout and anxiety? Where are we in that work-life balance, if you will, such that now burnout is becoming much more in the fore to have our discussion and our attention?
It's interesting. So in my other role, we talk to lots of people. And at the beginning of the pandemic, I think we as clinicians, the anesthesiologists, the nurse anesthetists in our department, both who are amazing. And I know that appreciation by supervisors, one of the things we saw positively correlated with lower stress levels. But that heroism, that, having the Blue Angels flying over the building, people were excited. That can only last so long. And then you're going to sort of take that dive. And then the worst thing that happened is we got a vaccine, but not everyone took it. So now we've got the stress of people saying this could have been over, but it's not. And you almost see a certain level of frustration and anger in the medical community. So I think that, and we know the social isolation. One of the roles I have is overseeing the nursing homes, and the effect of that social isolation was so profound of weight loss, depression. So we know that's in older individuals, but I think it affects all of us.
As you bring that up, I just had a flashback. Do you remember those early days pre-vaccine when people would go out on their balconies and beat their pots and pans and at every shift change, and it was intense. And then we got the vaccine, and we were all looking forward to this finally being over. And I think you're right. I think now it's just sort of this reverberating cycle of different types of frustrations and anger amongst the medical community, and we don't know how to channel that, and so perhaps we're just internalizing that in ways that are not healthy. No,
it's very anxiety provoking, and you struggle as a provider and as a clinician, with what you're feeling and what you should be doing as a provider, and it is very difficult to deal with.
It is a shame, and on top of that, we have staffing shortages.
Which is only continuing to get worse.
Frontline nursing. I mean, that is one of my greatest concerns today. Is whether or not we're going to have enough people at the bedside taking care of individuals. I mean, that was what was amazing at the beginning. If you think about it, anesthesiologists, nurse anesthetists, we were all saying, we can do anything. We've got our intensivists, we'll have those pyramids, our nurse anesthetists trained up as respiratory therapists. There were so many different opportunities, and now we're sort of back to routine every day, what we're doing, but we still have some of the stressors.
I heard a staggering figure that 30% of nursing had left the field. I don't know if that's accurate or not. I need to check that. But that just frankly scared me. Like, how do we do this?
I think we will recover. I think it would be, just dark to think that we won't.
Yeah.
But Lee, will we recover? I mean, will we ever go back to those days pre-COVID when healthcare was delivered by people who were eager to get up in the morning and go to work and do their job and derive joy from that?
I can only hope yes. Mm-hmm. But I'll be honest, one of my concerns actually is the frontline bedside nurse, because we have a lot of nursing, just like yourself, Desiree, who continue to want to practice and who will be taking care of the patient on the front line. But, my hope is that with all the mandates coming up and we're seeing the Delta variant decreasing. I heard Fauci, I think this morning, said, don't be excited yet. We've seen this before, but it's a little more optimistic. I think we're up to about 54% of the public being vaccinated. So I want to be there next year at ASA.
I know, hopefully. I wonder how we figure out, ways in which to support our frontline nursing. I know we are leaning in a lot in the world of anesthesia and physician communities and specialized communities, but nursing is a huge, there's so many people. What are we doing, to support them? Do you know?
We've been asking those questions, and asking them of the nurses. And I think, just like we want appreciation when we go to the ICU and drop off our patients, when we go to the PACU, just some level of appreciation. But even ICU nurses are specialized, as I'm sure. I don't know if you were in a cardiothoracic or a medical, but I'm sure you were an ICU nurse.
Yeah, neuro and surgery. But, well, Lee, talk to us a little bit about how we in the anesthesia community really kind of leaned in during COVID and how we lean in actually post-COVID and continue to highlight what we're doing in the world of healthcare.
Well, thanks. And I'm very excited. In about 45 minutes, I'll speak with my CMS hat, but I'll give you some areas where I think we have huge opportunities. I recently gave an interview to Tom Lee at the New England Journal Catalyst. And, one of my comments, which seems to have been well received, if we don't have equity, we don't have quality. And I thought a lot about that, and in last year's graduation, I even asked my graduates something that I hadn't done, which is, have we ever looked at, in our maternal labor and delivery, by race ethnicity, did we give similar epidural utilization or frequency as they asked? Did they have similar pain relief? A lot of questions that I'm hoping we will start doing is looking at those stratified approaches to see where can we make a difference. So maternal mortality, we know that there's a 1.5 to higher rate in the African American, the Black community, in other minority communities, and we should lean in and work with our obstetrical colleagues to see how we can improve those issues. The pandemic, as far as opioids, we had both COVID and we had an opioid pandemic. I think we need to lean in very heavily there post-pandemic and really make a difference. One of the interesting things in my role is I'm an anesthesiologist, the first anesthesiologist in this role. And we think a lot about emergency preparedness. I try to frequently say I'm always thinking about what can go wrong. When I give anesthesia,
Plan B, C, D.
Yeah, exactly.
Yeah. And I think, a lot of places have plans that are just bought off the shelf. And how can we work with our hospitals and ambulatory surgery centers to really go further in preparing for the emergency. And lastly, I'm going to give a commercial to Saul and a good colleague, Mark McClellan, who wrote about anesthesia and perioperative medicine as population health. So what's very clear, and again, I'll talk about it shortly, is I urge people to go to a health affairs blog by my boss, Chiquita Brooks-LeSueur, and some of the other colleagues in the Innovation Center and center directors. And there's a lot about population health and how to make the care coordination better. And Saul, I have to give you huge kudos for what you did at Duke.
Thank you.
I think that there are a lot of other places that either are copying. I think Vanderbilt, they're working on it. Michigan's working on some of these ideas. Even the social determinants, and I don't know if you've thought about this, Saul, but my hope is, as we develop some of our quality metrics, is if we find somebody who, as part of the pre-op, you've done smoke cessation, diabetes. I'm trying to remember all your clinics. But let's find they have housing insecurity. Or let's find they have food insecurity beyond acute. Could we know where there are NGOs, where there are the social connections that we can refer people to? And maybe you do that in Durham, so that they get long-term opportunities to improve their health. So I think there's both some of the phenomenal stuff you've done, but that's what I've been thinking a lot about long-term, about in how we improve those social determinants without necessarily owning them, but partnering, which would take not as much time, but it's a huge opportunity.
Firstly, thank you. Very gracious and sweet and kind of you to say those nice things. I agree. And I think it's importantly to also sort of add to that conversation that many of those people, particularly those people who are wanting of those elements of social determinants of health, don't have primary care physicians. So they're not plugged in. And so often their first touch point to health care is when they are declared surgical, when they have to confront the reality that they need surgery. And so the role of an anesthesiologist in that, preoperative sort of assessment domain to determine their readiness for surgery is the first time they've actually had connectivity to healthcare. And so all the more reason that not only do we need to tee them up so that they're healthy for surgery, but to ensure that there's a pull-through and that they have a soft landing afterwards. And I think that owning that responsibility as an anesthesiologist is really, really important and would matter.
I've made a few comments, and in fact, one of my comments on this interview with Tom Lee, he gave us great praise for what we've done for patient safety 20 years ago, and I gave my Rovenstein. I talked a lot about shared accountability. And Saul, what you're saying is you're willing to be accountable for ensuring the connections, not doing necessarily
exactly right.
the work itself. Because go where the experts are, but ensure they're connected, some of those experts. Some of it we can do ourselves. So did I get it right about how you're thinking about your clinic?
Precisely. And so it is care coordination as a buzzword that means that. But it's also to ensure a transition of care and to ensure that we're a facilitator to enable that patient to be plugged in, appropriately plugged into a system where they heretofore have been isolated from or just not connected to. And I think that's a really important role in the spectrum of healthcare delivery.
If I can, there's one last area that I would love to talk about in patient safety, and we're seeing hospital-acquired infections go up. Now, we don't know if that's in COVID patients or non-COVID patients. We're seeing other safety indicators. But what was really interesting when I heard someone talk about us.
You mean anesthesiologists?
anesthesiologist, the anesthesia, APSF, which we all think really highly. Jeff Cooper and the whole, that gang, was we engineered solutions, but we also were multidisciplinary. And I have to give a plug for a very dear colleague, friend, former, maybe still mentee in some ways, and Megan Lane Fall, who's really just become a force in nature.
Brilliant.
And it's all about that social environment that we live in, that we as anesthesiologists, it's not just the checklist. It's the checklist living within a culture of safety. And I think we need to go back and really help the healthcare ecosystem, which I talk a lot about after the pandemic, to rebuild with not just saying it's the culture, but it's not just saying the checklist will get us there, because I don't think it will, but the checklist, and use all we've learned about implementation to do better. So you'll hear, as I say shortly, my call to arms, which a call to action, as I talk about, as part of my all my talks these days.
Yeah, well, I mean, we actually had that conversation just earlier this morning about it. It's not about the checklist.
The theme is just becoming, it resonates in every corner and wall and hallway, and I think we need to get up and act beyond that sort of familiar and therefore comfortable but narrow zone that we've traditionally been sort of boxed into. And change is hard. I mean, change management is hard, but it's critical. Progress cannot exist without, accepting the need for change.
Yeah, the discomfort. Well, it sounds like, it really feels like that since the pandemic, it's given anesthesiology a platform now to be able to, a little bit taller platform, maybe, to be able to shout out about some of the things that, are important. Do you feel that way, Saul?
I do. I think, it is an unmet need. It's not like it's it's not like we're competing against it. It's very complementary, and it's a recognition that this space that we're talking about, this sort of connectivity, as you put it, Lee, is frankly unmet, and somebody needs to fill that gap, and it just seems to make sense for us to be a part of that, if not to lead it. And I'm hopeful, as you are, that we will. Yeah.
Well. Okay. Lee, thank you so much. It is always such a pleasure to talk with you about everything that you're working on. I don't know how you do it. I know it's
I
love.
Miss you.
I know, we miss you tons. Good luck on your lecture later today, and all the amazing work that you're doing that we can't really even talk about. But keep up the good work, and know we're here to support you, okay?
Thank you so much. Always a pleasure.
And congratulations. All right. Thank you so much for listening to TopMedTalk. You can always find us on your favorite podcatcher. We're on live.edpom.org right now. There's some wonderful conversations that we've already had here at the ASA over day one and day two. And we look forward to future conversations throughout the next couple of days.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EdPom, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out edpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out edpom.org now.